Mobile computing in healthcare has an important role in delivering high quality and efficient patient care and releasing cost savings. The Mobile Point of Care Conference 2009, hosted by Tracline, showcased real-life applications of mobile technology from trusts who've undertaken groundbreaking projects. Speakers also gave opinions on the future of mobile clinical assistance.
Salford's very much using mobile devices out on the wards, both for the nurses and the doctors and the pharmacists to use them when they're actually treating the patients. We're very lucky because we have an EPR, so it means they have instant access to real information. And we've also used it in areas like with a phlebotomy where they are moving around right across the hospital.
In order to make the best use of shared care record systems, we need to provide nurses who are working in the community with access to live systems. So the benefits there are around giving them real access to clinical records at the point of providing care. Also, if they've got access via mobile devices, they're able to go straight to a nursing home or a patient's home to deliver that care without having to go back to their office to access clinical records.
The results of all the pilots that iSoft has been involved in have given significant improvements in productivity. So we had pharmacists in each Cheshire reporting a 25% improvement in dose administration. We had nurses in Bangalore reporting an 84% reduction in time taken to record observations. So important improvements in efficiency.
Mobile point of care in prescribing, I guess, increases efficiency in as much that the patient's drug charts are on the computer system. So when the nurse gets to the bedside, she has everything she needs there in order to start administering drugs. In the old paper-based system, the start of any drug round was finding all the drug charts, the paper drug charts, before they could actually start doing a round. So it's much quicker to get the ward round going each time.
In terms of benefit realisation, the area that we focus on has been on phlebotomy, and we can clearly demonstrate that we've made the phlebotomist 20% more efficient, and we've also reduced the number of unnecessary bleeds that we used to do by 10%, and that is significant both in terms of financial benefit and also in terms of patient experience of not having to have unnecessary bleeds.
The typical nurse using mobile solutions can save in the region of about 40 minutes to 2 hours per day through avoiding unnecessary travelling. Primarily it's about improving quality of care. For example, if a nurse attends a very ill patient and they've perhaps not seen that patient before, if they've got access to the clinical record, they can quite often avoid that patient being admitted to hospital.
Without doubt, we would not have been able to implement some of the technology, or rather some of the functionality of electronic patient records without point-of-care devices. There's no doubt about that at all. So, for example, for inpatient electronic prescribing, unless you can record the administration of that medicine at the bedside in real time, you're really not going to achieve what you want to achieve.
In terms of improvements in patient care as the result of electronic prescribing, which inherently is mobile point-of-care prescribing, there is strong evidence from the system that we've been running for some years now that although there is clinical freedom in the system and doctors are warned and nurses are warned when they're doing something inappropriately or at first sight inappropriately, in many cases they have to do things in order to treat the patient effectively. However, there's also evidence that in a significant number of cases they change their mind and they behave differently and back off. So therefore, it does have an impact in reducing risk to patients.
The key success factors are around convincing the staff that they can work in a different way using this technology effectively. It's very much a change management programme. We have to be prepared to work and put significant effort in supporting staff using technology to support their role.
If we were to take the MCAs away from Salford, there would be an outcry. When we finished the original prototyping for the MCA with Intel and iSoft, the phlebotomists were in tears. They did not want to lose them. So no, Salford couldn't manage without the MCAs. It really has enabled the nurses to become much more efficient, to spend more time at the bedside with the patients, which for them is key,